All right, it is top of the hour, so we'll go ahead and get started here. You'll notice that there is a poll. We're just asking you if you are currently working on any neurology related tests, and if not, maybe you're planning to be. Lots of feedback already, so thank you for that. We really value all of our feedback that we can get from you, our customers, because it helps us present the most relevant information for you. So that brings us to today. My name is Anthony Austin. I am the Global Marketing Manager here at Medix Biochemica. We're excited today to have this webinar entitled Biomarkers, the Neurodegenerative Disease Game Changer. As has become a custom for these types of webinars, before they get to the exciting part, it's my job to give you a little bit of the housekeeping. So you will notice that the chat function is disabled for this webinar. However, the Q&A button is open, and we ask and even encourage you to ask us any question that pops up now or during the webinar. Or if you're anything like me and the questions only come until a few days later when you're taking a shower or you're driving home from work, if that is the case, please also at any time feel free to reach out to us with an email at the address info@medixbiochemica.com. That's info@medixbiochemica.com, and we'll be sure to get you the answers that you're looking for. We will hold a Q&A session at the end of this webinar. However, do be forewarned that it is a possibility that we get too many questions and we don't have enough time to answer all of them, or there might be some pretty tricky questions that require a bit of a technical deep dive before we can get you the answers that you require. So if that is the case and we aren't able to get to your question, we do apologize. However, rest assured that we will reach out to you to get all the answers that you need through a follow-up email at the conclusion of this webinar. This webinar, as you would have also noticed, is also being recorded, and that's so that we can give you an on-demand link to view it in the future and to share with any colleagues, friends, and family that might be related or interested in this topic. And it's also for the attendees or the registrants who weren't able to attend to view at a later point as well. Again, we really appreciate your time being here, and we welcome all of you. And if you aren't familiar with Medix Biochemica, we are an independent, international, and industry-leading raw material supplier, especially for the IVD industry. We've expanded quite a bit over the past several years, not only geographically, but also our product portfolio. On the geographic side, we've grown from having our main headquarters in Finland to now we include United States manufacturing sites in the United States, Germany, France, as well as China. And on the product portfolio side, we've expanded rapidly as well to not only include the monoclonal antibodies that made us famous, but now we also provide high quality and high performing antigens, highly purified proteins, clinical chemistry enzymes, molecular diagnostic reagents, biospecimens, base matrices, and a number of other different related types of raw materials. And we're excited that even as lately as a few weeks ago, we joined forces with Candor Biosciences, who are based out of Germany. And with that brings the expertise in the areas of immunoassay stabilizers and premium blockers. So very excited about that partnership and what that will lead to here shortly and in the future. Our main vision as a company is to become your first choice raw material partner. We want to provide you with solutions and services that allow you to do the work you do better. So to add quality into all of your tests or to advance the research that may be relevant to you. So we're excited to talk to you, learn more about your needs and how we might be able to come up with some solutions for you. And to our topic for today, we're very excited to be joined today by Professor Timo Maihonen from the University of Helsinki. He is an expert in the area of neurodegenerative diseases, and he'll be talking you through some slides and really talking about the use of biomarkers as it relates to early detection, as well as elucidating the disease mechanism for some of these devastating neurology-based diseases. After his presentation, we'll hand it over to our very own Dr. Maria Voutilainen, who is a global product manager here at Medix Biochemica, and she'll walk you through some of the more Medix Biochemica specific solutions that might be relevant to you if you're in this area. So with that, I will turn my video off, and Professor, I'm happy to, well, I'll hand it over to you and I'll advance your slides. I will turn my video and my audio off. And thanks everybody for the poll. I'll end that now as well. So let me stop sharing and I'll turn my video off and I hand it over to you, Professor.
So hi everyone, I'm Timo Myöhänen, as Anthony nicely introduced me. I will be giving a brief overview on the biomarkers in the neurodegenerative diseases. So we all get measured biomarkers every now and then. We go annually for a health checkup. The doctors take some blood from us, and if they detect, for example, high cholesterol, we get statins, and then we get reduced risk for infarcts and other circulation problems. It would be great to have similar, for example, for Alzheimer's disease. So you would go for your routine checkup. From the blood, there would be an increase indicating a risk for Alzheimer's disease. Then you would start therapy and you wouldn't get an Alzheimer's disease. The main problem at the moment is that we don't yet have a good disease-modifying therapy, but hopefully the biomarkers help us to develop them. We spoke about the neurodegenerative diseases, which is a heterogeneous group of diseases. The common thing is that they all affect on the neuronal system and on the CNS. And for all of them, we don't yet have an effective treatment that would actually block the progress of disease. Alzheimer's disease is the most common, totaling over 50 million patients and causing dementia. There is also several other dementias like frontotemporal dementia and several movement disorders like Parkinson's disease and ALS, amyloid lateral sclerosis. If you look a bit on the Alzheimer's disease and other dementias, the dementia refers to a progressive cognitive decline and memory loss, atrophy in the brain. And Alzheimer's disease is one of the dementias, but it's the most common. So it's approximately 70% of all the dementias are Alzheimer's disease. In the Alzheimer's disease, we see these amyloid beta plaques and also tau protein tangles that accumulate to the patient brain. We also see very intensive neuroinflammation that can be detected with these active glial cells that support neuronal functions. At the moment, all the therapies have basically poor or no efficacy on the disease progression. Then we have other dementias like frontotemporal dementia that lacks the beta amyloid pathology but has the tau pathology. And there the situation is even worse, so there's no specific treatments for the frontotemporal dementia. Parkinson's disease, then again, is a movement disorder that usually starts with tremor, rigidity, and reduced movements. In addition to the movement disorders, there's also several non-motor symptoms that may progress to the dementia. In the Parkinson's disease, neuronal cells that use dopamine in the substantia nigra start to die. We still don't know the reason why they die, although the disease itself has been known for more than 200 years. The current medications are based that we try to replace this dopamine. This has a good efficacy on the symptoms, but unfortunately it cannot delay the neuronal death or the progress of the disease. Another movement disorder is ALS. There, the neurons that regulate muscles start to die, again, for unknown reason. The disease starts with the muscle weakness, progresses and leads to the more severe muscle weakness all around the body. And in the final end, the respiratory muscles are also affected by the disease. This is rather fast. The disease duration is approximately 3.5 years, which makes it also very difficult to treat. And there's no disease-modifying treatment available. We do get minor effect by a compound called ridosol, but that is a compound that is designed to reduce the activity of overactive neurons, but the efficacy is not extremely good. Another disease, so to say, is a traumatic brain injury, and in traumatic brain injury, we could also have a beneficial effect from the biomarkers. In general, TB has an impact on head that causes damage to the brain tissue. And this can vary from mild concussion that I think most of us have got to even the piercing injury and it affects up to 50 to 60 million people annually. Of course, most of the TBIs are mild and people recover normally, but moderate to severe and also repeated mild TBIs are risk factor for long-term neuronal deficits and even to neurodegenerative diseases. So we first if we get a hit to the head, we get the primary damage, which can be hemorrhage, focal brain contusion, some neuronal axonal damages. And if the primary damages are bad enough, we get secondary damages, which are close to the mechanisms of neurodegenerative disease. We see excitotoxicity, inflammation, so on. And this might lead to the neurodegeneration or to long-term neurological deficits. Again, similar to other diseases, there's no effective therapies that could prevent these long-term effects of the TBI. So why we would need biomarkers? Most of these neurodegenerative diseases are considered to develop up to 10 to 20 years before the symptoms, which means by the time of the diagnosis, large number of neurons is already lost, and it's very difficult to bring the neurons back. So if we look, for example, the Alzheimer's disease, it's been estimated that here, about 10 to 20 years before the first symptoms, the disease starts with synaptic dysfunction, which means that the neurons are not communicating normally, progressing to the neurodegeneration. Finally, clinical diagnosis is done, the treatment can be started, and if we think about the clinical trials, the inclusion is even late. If we could have a good biomarker, we could detect, or probably detect the neuronal degeneration much earlier, which means that we could start the treatment earlier, or if we don't have a treatment, we could select patients for clinical trials earlier. That would probably increase the success rate of the clinical trials. So we would need markers for diagnosis, potential risk for treatments, and for the drug development. So what can be measured at the moment? Luckily, there are several options. One that has been studied a lot is a tau protein and phosphorylated tau protein that is there on the microtubules of the neurons. It's an essential part for neurons to communicate, to maintain itself, and basically to be alive. Other very much used is neurofilament light. That is also in the axonal part of the neurons, but when the axon and neuron damages, it's very easily leaks out from the neuron and also from the brain, and that can be measured. One marker that I will be speaking is GFAP, that is essential part of the astroglial cells that are glial cells, supporting cells, and they maintain neurons and, for example, blood vessels and blood-brain barrier in the brain. These markers can be measured from cerebrospinal fluid, CSF, which is the most accurate. But then again, it's invasive. It requires well-trained medical doctor to take the sample, and it's not completely without the risks. Blood sample is much easier, but then again, it's less accurate. Saliva is studied, skin biopsy is studied for certain diseases. They can be measured with various methods. One very widely used is SIMOA, which is a bead-based immunoassay, where we have particles with antibodies or coated with antibodies taking the target, and that can be then detected. Another one is ECL, electrochemiluminescence, where the idea is more or less the same. We have a good capture antibody, and the target is binding there, and that can detect the chemiluminescence. Also, immunoprecipitation mass spectrometry is used. There we need also antibodies, like all of these, but also some isotope labeled proteins, and then the detection by mass spectrometry. If you now go to the biomarkers in the Alzheimer's disease, there's this very much used picture, which is probably also quite accurate. showing that in the preclinical phase, when we yet don't have any symptoms, the amyloid beta, this bad fellow forming these plaques into a brain, starts to increase, and we start to see first soluble amyloid beta, 10 amyloid beta plaques. After that comes tau, and it appears that tau is the killer, because after the tau starts to aggregate from tau tangles, we see neurodegeneration, and then, of course, the cognitive decline. And the diagnosis is done somewhere between the prodromal and dementia states. The amyloid beta has been studied a lot as a drug target and also as a biomarker. And we can detect reduced amyloid beta peptide or changes in amyloid beta peptide ratios in the CSF. And this is at the moment used to verify Alzheimer's disease diagnosis. Of course, the plasma would be better, but the changes in the plasma are very modest compared to the CSF. And the predictive value is a bit questionable from the plasma. So it seems that tau and different phosphorylated tau forms are way better for Alzheimer's disease. As I said earlier, tau is usually there on the microtubules, and it regulates them, keeps their structure, and allows certain modifications. In the Alzheimer's disease, tau starts to phosphorylate very effectively. And after this phosphorylation, it's released from the microtubules, and then the microtubules start to degrade, and eventually this kills the neuron. This released tau can be detected both from the CSF and blood. And at the moment, the most promising ones are two phosphorylated tau forms. So tau phosphorylation in position 181 and in 217. And they both have now become quite widely used biomarkers for Alzheimer's disease. The phospho-tau 181 was the first one, and it's currently approved as a CSF marker by FDA. It seems to detect more aggregated tau, and particularly if you have amyloid beta positivity, either by CSF biomarker or imaging, it's very accurate. It can be used to verify the diagnosis, and it seems that both plasma and CSF levels correlate, so you can also take the sample from the plasma. And it's estimated that it can predict even to 8 years before the symptom onset. However, the phospho-tau 217 seems to be quite a game changer in the Alzheimer's disease field, because it's now been approved as a plasma marker. It seems to detect a bit earlier forms of tau aggregation than 181, and it has better detection between the Alzheimer's disease and non-Alzheimer's disease, some other dementia, like, for example, frontotemporal dementia, compared to phospho-tau 181, even without the amyloid beta positivity. It's been estimated that increased levels in the CSF plasma of phospho-tau 217 predict the symptom onset over 8 years before. There's one prediction from a couple of years back showing that in the best case, the phospho-tau 217 could go back to 21 years before the symptom onset. Phospho-tau 181 up to 90 years, and then total tau a little bit less. So, of course, this would be significant if we could detect the people who are in risk of developing Alzheimer's disease 20 years before the symptoms. This, of course, needs, then again, better treatments. What about tau and phospho-tau in other dementias? For example, frontotemporal dementia, where we know that tau is quite commonly aggregated. These diseases don't have amyloid beta, and other specific thing is that the degeneration is, particularly at the beginning, focused on the prefrontal areas of the brain, so here in the front of the brain. Interestingly, though, that there is usually tau pathology, but these phospho-tau markers doesn't seem to work very well. For example, in the frontotemporal dementia, they seem to be specific for the Alzheimer's disease. However, if we measure CSF total tau, that's increased in the frontotemporal dementia, and it also predicts worse symptoms and faster disease progression. So maybe this tau can be used as a diagnosis if amyloid beta is excluded. And then it appears that we haven't found those phospho-tau forms that are specific for other dementias than Alzheimer's disease. We have a couple of other tempting oncoming biomarkers, maybe for frontotemporal dementia and also for ALS, and one of them is TDP-43. That is a protein that regulates several functions in the nucleus. But both in the ALS and in the frontotemporal dementia, it exceeds the nucleus and starts to form aggregates in the cell. This disturbs significantly cellular functions and leading to neuronal death. Increased TDP-43 levels have been measured in the CSF and plasma of ALS and frontotemporal dementia, but unfortunately it cannot differ these two diseases. However, maybe this can be used as a marker if we want to target TDP-43 by some drug development process. Another one very widely used is neurofilament light. A bit similar as how neurofilament light is there in the axons of the neurons. And if we have an axonal damage or axonal degeneration, neurofilament light leaks very easily to the circulation. It's very highly increased, particularly in certain diseases, in CSF, but also in the blood. And quite commonly, it indicates the faster disease progression. For example, in dementia, it correlates with faster cognitive decline. This can be used part of the diagnosis, for example, in the Alzheimer's disease, or there are differences in different variants of frontotemporal dementia, but maybe it could be also a good biomarker in the clinical trials if we want to see, have we been able to reduce the rate of the neurodegeneration. Tricky part with the neurofilament light is that it increases by age, so the age needs to be taken also into account when detecting the neurofilament lights. In ALS, the neurofilament light is quite highly elevated, particularly in the early phase, and it can be used as an indicative for neural degeneration, and the increase is usually much larger than in the other neurodegenerative diseases, so maybe it can be used to classify the ALS from other neurodegenerative diseases. So it's a good marker for disease progression, and maybe also, again, if we have a disease-modifying drug candidate, it might be a good to assess its efficacy. But we would also need for the ALS mechanism-based biomarkers that would be earlier, and these are still under the investigation. In the traumatic brain injury, we would need biomarkers. First of all, of course, assess the severity of the TBI, and second of all, predict the secondary outcomes and those patients that are in the risk of developing long-term effects and potentially even the neurodegeneration. Neurofilament light has been rather good marker for the outcome prediction. Well, higher neurofilament light after TBI, more probable secondary damages. Also, it's pretty good on estimating between the mild and more severe TBI. Is there a need for CT imaging or other treatments? Later, if the neurofilament light is elevated still 1 year after the TBI, it can be used as an indicative for a neurodegenerative disease that might be developing behind. However, of course, again, we would need some therapy to block this process, but at least we seem to be able to detect which patients are in the high risk of developing the neurodegenerative disease. One interesting biomarker under investigation is UCHL1, ubiquitin C-terminal fibrillase L1. It's a protein that is involved in the protein degradation process and metabolism, and it's very specific for neurons. So if we think about the TBI biomarkers, neurofilament light and and GFAP that I'm going to speak a bit more later, they are related to the axonal damage, neuroinflammation, and glial cells. And UCHL1 is more specific for the neuronal damage. It's elevated quite rapidly after the TBI, but if there's both UCHL1 and GFAP elevation, that can be used as a prediction for poor outcome after the TBI. Then we get to the GFAP, Glial Fibrillary Acidic Protein. It's an essential part for the astrocyte cells. And astrocytes that we have quite a lot in the brain, they support neurons, they support blood vessels, blood-brain barrier, and they're very important for the brain tissue structure. They're also reactive for the damage. They're part of the neuroinflammation, and they are part of major players in the brain repair process. After TBI, we see quite a lot of damages in the blood vessels and in the axons. And that's why elevated GFAP is a good marker for this, and also probably for the repair process that would indicate for the larger damage. If we see high acute levels of GFAP in the plasma and CSF after the TBI, they usually correlate with higher damage and can be a reason to make a CT imaging and detect the damage. This long-term increase, lasting months to years, then again predicts cognitive impairment. This is particularly good in the moderate or severe TBIs, and maybe this could be used to predict the outcomes and modify treatment. In mild TBIs, GFAP is a bit more controversial. It seems to be going up and down, and it's not very good indicative in the mild TBIs, particularly in the acute phase. But more severe TBIs and in the longer phase, it's a good indicative for potential risk for the neurodegeneration. So here in this image, we see that in the acute phase, we see elevation in various markers, including GFAP, Neurofilament Light. We have a prolonged release, for example, Neurofilament Light, GFAP, that may indicate for the risk of neurodegeneration. And of course, in time, if we start to see increase, for example, in the phospho-tau, that's a very good indicator for the neurodegenerative disease that is progressing. GFAP can be also used in other diseases, and in the Alzheimer's disease, it's very reactive for the amyloid beta and other cytokines that are released in the neuroinflammation. It's elevated before the diagnosis, by the time of cognitive impairment, but it continues to increase. And particularly in the amyloid beta positive dementia, meaning Alzheimer's disease, and this can be maybe used to differ from other dementias. And similar to various other biomarkers, higher levels correlate with faster cognitive decline. In the ALS, GFAP may also predict the disease progression, and in the frontotemporal dementia, it may differ between the disease subtypes. So there is different subtypes in the FTD, like behavior and language variants, and it seems to be that GFAP is more elevated in this behavioral variant of FTD. Parkinson's disease is also elevated, but also only with the patients that are developing a Parkinson's disease dementia. Parkinson's disease is a bit more tricky in the biomarker field. GFAP generally is not elevated, but as I said, if there's a Parkinson's disease with dementia, then it usually increases. Then again, GFAP might be able to distinguish between other movement disorders like multiple system atrophy or progressive supranuclear palsy. Neurofilament light, similarly, not elevated, particularly in the early of the disease, but maybe can be used to discriminate between these other movement disorders. But alpha-synuclein is one that is a potentially good biomarker of Parkinson's disease. Not the detection itself from the CSF or blood, But if we use alpha-synuclein into seed amplification assay, we are able to detect these toxic forms of alpha-synuclein protein that accumulates to the brain of the Parkinson's disease patients. It's based on the idea that these toxic forms of alpha-synuclein are able to transform normal alpha-synuclein to this toxic form. And this is something that we can detect. This can be used as a diagnostic marker. Its accuracy is more than 90% if we combine it with a prodromal symptom like hyposmia or sleep disorder. Unfortunately, this is yes or no. So it doesn't show how much there is alpha-synuclein. So for example, if we want to follow up potential disease-modifying therapy targeting on alpha-synuclein, does it have an effect? This cannot be used for that. And at the moment, only the CSF sample is accurate, but saliva and skin biopsy sample assays are being developed. A brief overview on these different diseases and their biomarkers. So Alzheimer's disease, we have a great progress at the moment with phospho-tau 217, and it seems to have a good predictive value even from plasma. Neurofilament light and GFAP can be used as an additional biomarkers showing on the disease progression and neuron damages. Frontotemporal dementia and other dementias, these phospho-tau forms are not very reliable. Total tau seems to predict faster prediction, faster progression, and but it needs to be taken usually from the CSF. Similarly, neurofilament light and GFAP, they correlate with faster progression, maybe be different between different variants, and also may predict the faster cognitive decline and other symptoms. ALS, the neurofilament light, seems to be a good biomarker. It's particularly increased during the disease progression, can be even used as maybe as a diagnostic marker. GFAP has been studied there as well, but it's not as good as neurofilament light. And then traumatic brain injury, where the neurofilament light as well is a good biomarker, predicting the outcome to separate from mild to moderate TBA, and elevated GFAP as well, particularly if it's elevated long-term, predicts cognitive decline, potential neurodegeneration. Well, when we think a bit about if there's what are the positive and negative things with the better biomarkers at the moment, of course, there's a lot of positive things. We get better diagnostic accuracy. We can start the correct treatment faster, because with some of the diseases, there's a long diagnostic period, may delay the treatment. We start to have predictive diagnostic biomarkers indicating people who are in risk. So we have a possibility for pharmacological or non-pharmacological interventions, a little bit like high cholesterol and statins and reducing the use of fat in the food. Maybe we could make even a routine blood tests in the future. And we have better tools to follow the disease progression, which is particularly important when we try to develop disease-modifying therapy. But there's also some negative issues. I mean, neurodegenerative diseases are very serious diseases. People know that there's no good treatments. So the accuracy needs to be very good. The emotional stress of a false positive of the diagnosis, it's huge. The other problem is also that we don't have the disease-modifying therapy for most of the neurodegenerative diseases. So if people gets an information that I'm in risk, but there's no therapy available, how does that affect on the potential patient? Of course, non-pharmacological interventions may delay the progress. And for some assays, we still need invasive sampling, which means CSF sample, which is not completely without the risks. About the future, how it looks like. I'm quite sure that in the future, measuring markers for neurodegenerative diseases is somewhat routine as we now measure high cholesterol. We still need even more accurate blood-based biomarkers. I mean, other sampling methods, mainly CSF sampling, is too invasive. They need to be accurate enough. We don't want false positives. Is it going to be one marker combination? Maybe a combination. And I hope to see even more novel biomarkers. As we saw, for example, for other dimensions than Alzheimer's disease, we don't yet have a very good diagnostic or predictive marker. And we're going to need a disease-modifying therapy, which is, of course, one difficult task. But if we catch the people in risk beforehand, if we can start clinical trials earlier, we have a better chances of success for the disease-modifying therapy as well. Thank you very much for listening.
Okay, thank you, Timo, so much. That was really, really interesting. So now to my part of the webinar. So on my behalf as well, thank you everyone for joining. My name is Maria Voutilainen, and I'm the Global Product Manager for the Neurology clinical area. I will start my part of the presentation by briefly introducing Medix Biochemica and then showcase the products we have available for diagnosing neurological diseases and conditions. In addition to neurology, I also oversee the portfolios for drugs of abuse, hormones, therapeutic drug monitoring, and veterinary diagnostics. And while we are not going to be discussing these analyses at all today, please feel free to reach out if you are interested in learning more about them. So for those of you who are not so familiar with Medix Biochemica, we have 40 years of experience in producing premium quality, high sensitivity monoclonal antibodies. We have a strong global presence with sites in Europe, the US, and China, which enables us to serve customers across the world. Our vision is to be the first choice raw material partner for the IVD industry, and we are already the trusted partner for a range of diagnostic companies worldwide. Medix Biochemica is foremost known for its quality. We maintain high standards with consistent lot-to-lot quality and minimal variation, and we are ISO 13485 certified globally. We can produce large quantities of materials when needed. We have highly scalable production capabilities with batch sizes up to tens of grams and an annual capacity on a kilogram scale. And most importantly, we ensure reliable on-time delivery of these products. When it comes to scientific innovations, we work very closely with you, our customers, to develop new products and to understand what is up and coming in the different clinical areas. We also offer co-development of new materials, and we have put efforts into generating application data on our products in various testing formats. Through our own developments and acquisitions, we have built a very comprehensive portfolio of products that supports assay development and validation with over 5,000 products for different clinical areas. So as previously mentioned, we supply a wide range of products across various clinical areas, including antibodies, antigens, biospecimens, and more recently also stabilizers and blockers. So essentially, Medix Biochemica provides many of the raw materials necessary for developing diagnostic tests. Here you can see some of the clinical areas that we currently support. But obviously today, we will focus on neurology and what we can offer you in this particular area. So recognizing the importance of diagnostics for neurodegenerative diseases and conditions, we have focused on developing a variety of monoclonal antibodies targeting relevant analytes that you can see listed here. Among our most recent launches are, for example, GFAP and phosphatide-217, of which Timo discussed already, and about their importance. So we have, for example, these in our portfolio. And in addition, we offer other tau fragments and many more analytes, such as different neurofilaments and for example, UCHL1 that was also mentioned just before. So overall, we have over 58 products related to neurology, and these include both primary antibodies, recombinant antigens, and various biospecimens. And if there would happen to be something that you actually cannot find in our catalog, you can always contact us. As mentioned, we are very happy to co-develop and collaborate on the development of new maps and other products. So for all our monoclonal antibodies, we offer multiple options that also work as pairs for detection. We also provide pair recommendations for all of these analytes, which can be viewed in detail, for example, on our websites under each product. So for example, if we look at tau proteins, you can find the pair recommendations we have available and see that our phosphorylated tau proteins form pairs with the total tau detector antibodies. And similar information can be found with other analytes as well. So as Timo very nicely already discussed, some biomarkers are specific to a single neurodegenerative disease, but they can also be shared across multiple conditions. When we look at the analytes Medix currently offers, we can categorize them based on their diagnostic purposes, for example. Biomarkers are obviously crucial in the diagnostic process. They can give us early indications of a disease, often before clinical symptoms appear, allowing for earlier intervention and potentially better outcomes. And measuring these biomarkers may also help clinicians differentiate between disorders based on their altered levels. And obviously, beyond diagnosis, biomarkers are essential for monitoring disease progression and evaluating treatment effectiveness. As biomarker diagnostics advance and tests become more readily available, clinicians can one day track how disease is evolving and adjust treatment plans accordingly. This is particularly important in neurodegenerative diseases where progression can also vary significantly between different individuals. And as an antibody manufacturer and provider of various raw materials required for these tests, Medix can aid in advancing and in the development of diagnostic tests required for diagnosing these various conditions. Which then brings us to one of our latest additions in the neurology portfolio, amyloid beta. So amyloid beta is one of the earliest biomarkers used in clinical settings to assess Alzheimer's disease pathology. We have now recently developed antibody pairs to detect amyloid beta 140 and 142, as well as a general amyloid beta map for the N-terminus that can be paired with these specific C-terminal ones. We are launching the amyloid beta 40 maps in March of this year, so really soon. And the amyloid beta 42 is soon to follow and will be commercially available during summer 25. And already now we have availability of test materials. So if you're interested, please be in contact and we can send you something for testing. And here in the picture, you can also see our data on the performance of these maps with CSF samples for the amyloid beta 140 pair and the correlation with known concentration measured using a CE marked assay. And now that I have introduced the neurology portfolio and all the analytes we have, if you are interested in testing some of our antibodies, we are now offering these antibodies for free for a limited time. And you can, for example, go check out our webpage at medixbiochemica.com and order your free samples from there, or let us know after the webinar that you would like to receive samples. We are very interested in hearing your feedback about these. And here in the picture, you can also see the list of samples that are qualified for this offer. And then finally, in addition to antibodies and antigens, we also offer a wide range of biospecimens, which are essential for developing diagnostic tests related to neurology. So we provide a custom collection criteria for all our biospecimens, which ensures that samples meet the exact requirements for specific uses. So, for example, we offer CSF samples from single donors with data on age, gender, and collection date. And we also offer demographic and disease or severity selection if that is needed. Additionally, we perform infectious testing on the samples and the donors. And our capabilities additionally include target analyte testing, reporting, and providing detailed reports on specific analytes. So for specific neurodegenerative diseases such as Alzheimer's, we provide various sample types, plasma serum and CSF samples with relevant data, and we also have paired sets available if needed. And for larger needs, we also supply bulk and pooled volumes. And besides Alzheimer's disease, as you can see in the table over there, we also have samples for other neurodegenerative diseases such as Parkinson's disease and others. And should you need any other biospecimens, please feel free to contact us. We also offer customized biospecimens collections. And with that, I also say thank you, and I'll give the floor back to Anthony.
Excellent. Yeah, thank you both. I'll bring up my screen one more time. Yeah, thank you both. I'm, even after years of in this industry, I'm still fascinated by the fact that we can, one, detect these proteins and quantify them, but not only that, we can actually say you have this disease or you're probably going to get this disease. So it's really fascinating, and it's really encouraging to hear all the progress that's being made, especially in this area of such devastating or impactful diseases. So again, I thank you both for the talk, and with that, I'll thank you all, and you know what, and thank you for all the participants and for who have given our feedback to date so far as well. I do have one more question for you guys before we get into the questions and answers. And that's just for your feedback for the webinar. We want to make this as useful for you guys, and so we always strive to improve and take your feedback. So if you don't mind, and if you're willing to follow this QR code, we'd love to hear your feedback there. And another thank you again for all the people who have submitted questions. Like I said, we'll try to get to all of them. Apologies if we can't get to yours. So let's see. This first one, I think, is for you, Professor Timo. It is, I'll reword it just a little bit. It's, which biomarkers would you say are the most encouraging or promising for Alzheimer's disease?
That's a good question, but I would say almost ultimately at the moment, the phospho-tau 217 is the best biomarker because it's accurate even from the plasma. It seems to have a very good reliability, good prediction, and it can be used probably as a diagnostic marker in reliable way already now. I mean, then again, if we think about the drug development, that is more my field, then I would combine probably the phospho-tau 217 with GFAP or Neurofilament Light so that I could detect and follow up the efficacy of the treatments.
Excellent, thank you. This next one is, I'll stay with you. It's kind of a similar question. It's really how extensively are these biomarkers being used currently? And they asked a follow-up question. Do you think that the use of biomarkers will eventually overcome or replace the imaging techniques?
Well, at the moment, the CSF amyloid beta is used quite routinely as a biomarker. So that is commonly used, but then again, if you think about the CSF puncture, it's not completely without the risk. So there is always a risk for infection and this kind of a specific headache caused by the CSF puncture. So I would say that if we want to use more biomarkers, if we want them to overcome the imaging, then we're gonna need blood-based biomarkers that are very accurate as well. And if we get those, that may replace some imaging techniques like amyloid PETs or similar. But at the moment, since we don't have that accurate well, except maybe for the Alzheimer's disease, we start to have accurate biomarkers, we still need the imaging. But maybe in the future, they will replace these most widely used imaging at the moment, like amyloid beta, for example.
Excellent. Thank you. Maria, now to you. I know you mentioned it earlier, but I'll ask it again because I think it's an important point to make. Somebody submitted a question saying, I'm looking for a specific marker for neurology, but I can't find it on our catalog. Can I ask you to make it, or can I make a suggestion for development?
Yeah, good question. And as I briefly mentioned during the presentation, we really are open to suggestions for new antibody development and collaborations. And we really do consider all customer requests and then evaluate them based on technical feasibility and how much potential there is. So definitely, if you have any suggestions, hopes and dreams, feel free to contact our team and discuss these specific needs, and we'll be sure to assess them in more detail. You can just contact us, or then visit our website. There's a contact us form which you can access and be in contact with us.
Perfect. Yeah, thank you. Here's another good question for you, Professor. Let's see. For many neurodegenerative diseases, recognizable symptoms appear relatively late. Should people in their in their 50s be screened with some of these biomarkers?
Well, yes and no. I mean, phospho-tau 217 is already, it has quite a long prediction on Alzheimer's disease, which would be, of course, reasonable to detect if you are in the risk or not. But on the other hand, we don't yet have an effective treatment for Alzheimer's disease. So it's kind of a, like, I'm in the edge of thinking that should it be screened or not, because when we think that you get the diagnosis that, okay, you are on the progress, potentially developing Alzheimer's disease, but sorry, we cannot treat it yet. It's quite a stress for this person.
Yeah.
But if we get an effective treatment, then for sure, yes.
Okay. Yeah, good answer. And it really is, it kind of highlights the importance of diagnostics, because you're never going to be able to develop a proper treatment until you can detect it. So it kind of one has to come before the other. So it's really encouraging to see that we're really on that place where the next step is to look into the treatments now that we can detect it and measure it. Perfect. Let's see. We are currently, I guess this one is for you, Maria. We are currently testing several analytes from Medix Biochemica. If we would happen to run into any issues, can you troubleshoot, or can you help us troubleshoot or provide support in that way?
Yeah, oh, happy to hear that you are already testing some of our analytes. And to answer the question, yes, definitely we can support. We have really good support for these sort of things, and our team is always very happy to help resolve any issues that you might encounter. So you can, for example, reach out to our customer support for assistance with any technical difficulties or questions that you might have during the testing process. And then additionally, our R&D team is happy to have a call with you and discuss troubleshooting in more detail if this would be necessary.
Excellent. And we'll stay with you. I know we had it at the last couple slides. And by the way, all these slides and like I said earlier, the recording will be available. But just to reiterate, what for you, Maria, what new analytes do we have for the neurofield coming up?
Yeah. So, well, as I already showed, we do have quite a range of analytes already available, and one of the most recent launches that we have in coming months is the amyloid beta. So that's going to be the newest member to the portfolio. But we are constantly collecting feedback on our products, and also we do consider enhancements and upgrading products when necessary. And as I said, if there are any new suggestions that you would want to see in our portfolio, we're also happy to hear about that. But the amyloid beta is the one which is up and coming next.
Perfect. I look forward to it. I think we have time for 2 more questions, and one for each of you. And this one, I'm particularly interested in the answer as well. For you, Professor, what do you see as the future of diagnostics for neurodegenerative conditions? Are we moving towards blood-based assays as the routine test?
I think at least in the Alzheimer's disease, yes. Yes, we are moving towards it. I think the phospho-tau 217 test was taken into a clinical practice already in Finland. So yes, we are moving towards that. As I said in the previous question, we still need the disease-modifying therapy in order to have like a full package. For other neurodegenerative diseases, we still need to work with those. We still need more specific biomarkers so we can have a better, accurate diagnostics. But I would say that this is where we are going. Alzheimer's disease has been very rapidly progressing for the last, let's say, 5 years in the biomarker field, and I hope to see the similar progress in the other neurodegenerative diseases as well.
That's excellent. Yeah. Much better than having to always get your CSF measurements.
Yes, yes, for sure.
Much easier. Okay, yeah, and one last one for you, Maria, to close it out. I'm happy that somebody asked this one because it's an important topic for you and for our company as a whole. How is Medix Biochemica addressing sustainability?
Oh, that's a really, really good and relevant question as well. I think something that should be asked from every company. So at Medix Biochemica, sustainability really is one of the key values that we have. We, for example, prioritize high product quality, chemical and biosafety, and also customer satisfaction. Plus, currently we are working on reducing our carbon footprint, recycling waste at our different sites, and optimizing resource usage. If we consider our supply chain, we also hold that to high standards for quality, reliability, and environmental and social responsibility. And also, if we consider our products in more detail, we have recombinant capabilities for monoclonal antibodies and antigens, and we offer animal-free production. This is really important as well. And something that we are especially proud of from last year is that we received the EcoVadis silver rating, which basically places us above 89% of the companies assessed for the sustainability practices. So we really are high on those sustainability topics compared to many other places. So sustainability is important for us on a personal level and important on a company level.
Excellent. Yeah, thank you so much. So with that, I know we're running out of time. Again, I want to thank both of you for the webinar. We really appreciate you running through that. And I want to thank everybody for the feedback, everybody for the input, and for the time. Again, we will reach out to you with the transcript of the answers that you found here and the other ones that we couldn't get to, and we will make the recording available to you through download so you can share it with your friends and family for anybody who might be interested. And we look forward to doing more of these in the future, and we hope you all have a great rest of your day and rest of your week. Thanks, everybody.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye.